2 minutes. Give us an introduction. Nilay, begin with you.
Yeah, thank you. Nilay, Shah. I am the managing director at Delta Airlines. I oversee all our health and wellness benefits, disability and workers' comp, as well as analytics and innovation. I've been there 4 years. Prior to that, I was at Mayo Clinic for 17 years, leading division of healthcare delivery research there.
Shamas, CEO and founder of the Villager Network. We're an early stage startup. What we do is help nurse practitioners in particular build and operate independent primary care practices that they own and work with them to put them on a path to participate in risk-sharing agreements.
Hi everyone, Jeremy Kreyling. I lead data strategy for NeuroFlow. Those of you that aren't familiar with NeuroFlow, we work with both providers and health plans. We're a technology or software service that helps identify undiagnosed, underdiagnosed behavioral health patients. And those patients that are diagnosed, we continue to monitor them so that when they elevate in risk, we're able to surface them to their primary care providers or their care team or care management, and then identify the appropriate level of intervention that will meet their needs. In my role as overseeing healthcare informatics, really one of the two things I'm really focused on is enhancing our clinical benchmarks and making those available to our partners so they can evaluate their programs on their own. And then for all of the data that we collect and the insights we generate, making sure that information is not just actionable, but also accessible to our members' care teams. Thank you.
Thank you. So we have a very diverse panel here representing employers, providers in the underserved communities, and a provider. So let me begin with you, Nilay, and say, with regard to data and as a large employer, how receptive has your population been to the use of data, and particularly the privacy aspect, the fact that the employer not only knows all this information about them, but is also involved in some way in the delivery of their care?
Yeah, thanks so much. So just for context, Delta Airlines, we have about 110,000 employees, 200,000 members on our health plan. And one of the things that we did, and we felt this was important for us to do internally, is we invested in building a data platform. This was about 4 years ago. And a key piece of that was ensuring privacy. And at that point, we partnered with DataVant to tokenize our data. So all the data we bring in is tokenized, de-identified, and also we do a lot of auditing of where the data sits in our environment. And the way it works, we build a lot of different types of models, be it identifying high-risk folks that are using emergency rooms at higher rates, or people that may have specific needs related to maternal health that we want to prevent poor outcomes. What we do is we run the models and send it to our partners, who is our advocacy partner, Quantum Health, to run it on the data. They have the identifiable data. We don't have the identifiable data. So that's one way we ensure that we protect the privacy. But the second piece of it, what we've heard a lot from our employees is difficulty accessing care in a timely way. So what's happened over the last 4 years our team's spent there at Delta Airlines, people often have trouble getting in for whatever, specialty care, primary care, et cetera. They've started reaching out to our team to sort of say, can you help facilitate me getting in for this type of care? What are my options? Can I talk through it? We literally get probably 30 to 50 phone calls a week for this. Even though we have Quantum Health, which is the first point of contact for our folks, they oftentimes, so that's built trust over time that we're really there to help enable their health and wellness overall. So that's been a positive way, but one of the ways we sort of balance the privacy, but also build trust in the process.
It's interesting that you use the word tokenization, because I think those of us in this room understand what that means. But the average person on the shop floor or in the airplane is hardly going to react very positively if you say to them, as we tend to do with these terms, oh, we've got it covered with tokenization.
Yeah, no, and part of the, again, the way when we communicate, we basically say it's de-identified data. Now, the problem we were just talking about earlier, data is never truly de-identified, so we have to, we sort of explained that there is no way we are ever going to identify any individual. We audit who's using it for what purpose, so we ensure we have all of those safeguards in place to protect privacy, but we say tokenization amongst our team, but otherwise it's de-identification.
That's great. Jeremy, you represent an important and very rapidly growing sector in specialty care, behavioral health. I was recently involved in writing a paper for a client that manages depression and anxiety. And one important finding from this paper was that the patients that generated savings were the ones with chronic conditions. And the patients that didn't have a chronic condition didn't, in fact, they cost more as a result of the intervention. Is this your experience, and is there a way that you can focus the interventions through using predictive modeling or AI?
So that's a really good question, insightful question about behavioral health program savings and how that aligns to certain segmentations or segments of a population. Our research or our findings are directly aligned to your research. We do see that when we are doing program cost savings, the lion's share of the savings are attributed to that high acuity population with one or more chronic conditions. We've seen that over and over again to the point where we just know now to expect it. Also, what's interesting is the cost dynamics of the mild to moderate population. And I think you hit on it, Ian. We are seeing increased utilization in those populations. We do see ER utilization, avoidable hospital utilizations drop, but it's offset by increases in what we would consider good medical spend. This is preventative care, this is planned specialty visits, this is increased medication adherence, and we do see that those increases do offset some of the cost decreases. So we're really mindful when we go into relationships, whether it's on the payer side or the provider side, to reiterate that behavioral health integration don't directly reduce cost. What they do is they optimize utilization. And when you optimize utilization for some segments of the population, that will translate into a decrease in total cost of care. For other segments, that'll translate to an increase in total cost of care because they're not doing this preventative care and other types of care that they should be doing to take care of their health in the long run. From an analytics perspective, yes, we use our experience to start to stratify the population, to identify the specific segments, then start to forecast to predict what we expect the utilization to look like with an appropriate care program in place. And then a lot of times it's starting to educate the clients that knowing that there's going to be some subsets of the population that we're going to see an increase in utilization, let's start thinking about other programs or tools that you have that you can start to manage this spend, whether that's capitated models or other types of value-based agreements.
That reminds me of I think I've referred to this before, that one of the reasons that programs fail, in my opinion, is this idea that, well, we're not making our savings on whatever population we're managing, so we've got to increase the volume. We have to get more patients into this program. And of course, at the margin, they're not going to drive savings for the program. So that seems to be a common fallacy in many programs. Well, let's turn to Roger. The Villager Network addresses underserved communities, and given that these patients often not only don't have access to healthcare, but whoever's managing the patient doesn't have access to the patient. Is this a population that you can even think about addressing with value-based care? How do things work in your model?
Yeah, it's a really great question. And I think the answer in short is yes, it's possible, and it depends. It depends on the context and the payment policies in place. In Massachusetts, there's a fairly attractive, Mass Health has a really good ACO policy in place, and the economics actually can work there to deliver the fully integrated primary care behavioral health integration and provide the wraparound services required to keep those very vulnerable segments of the population out of hospitals as much as possible. In other states, Medicaid is state by state, it doesn't work. So I think that's part one. Part two, there are different ways of doing it around. I think there are two opportunities here. One is how will you do it through the business model, and then two, what technology enables you to do a little bit more effectively in terms of outreach to those segments. The business model aspect is where the policies are not make it very unattractive in terms of unit economics for the practice owners. We found that many of our partners are willing to forego some earnings to support some of the more vulnerable segments. And that only works because there is a net gain in our business model for NPs because the relative earnings as a function of reimbursements for NPs is better when they're operating independently. Part two is technology, of course, in terms of how we can engage. We got to the Gen AI and the conversations earlier about engagement. Obviously, that just makes it easier potentially to engage some of the individuals who have access to phones, who potentially could check emails. The really hard segments, still harder, but we're bending the cost curve, I think, with new capabilities over time.
Thanks, Roger. I'm going to ask a question that was prompted by Jim from the previous panel that in an earlier discussion, and it's a more existential question, if you pardon that word, about value-based contracting as a whole. Do we think, and this could be for the audience as well, is value-based contracting working? And the follow-up to it is, if not, why not? Anyone?
I can start. I'll take the employer lens. Value-based contracting almost doesn't exist in the employer space, right? And so we, as an organization, had to build our own contract. We went live with a partner just this year, and this is the first experience, so we'll know how it's working at the end of the year, next year, and what are the pitfalls there, but it really doesn't exist. We asked our carrier, we were like, okay, of our well over $1 billion in spend, what dollars are at risk, any risk, right? It was less than $1 million. And so it just doesn't exist, and carriers don't bring those programs to us. So at least what I've seen over the last few years, it really has to be us as employers having to drive that space.
I have seen it work in some areas, specifically procedural episodes of care. I think when you look at joint replacements and bundled payments for maternity, I've been a part of programs between providers and health plans and measured the savings, and they were absolutely there. But it's a special relationship to get there with the provider and the payer because there's a lot of data transparency that needs to be in place. And I don't know if those are scalable, but I know that they can work.
But the amount of dollars that are at risk in those kinds of contracts is probably much less than in the typical sort of chronic condition models that we see. And I'm reminded back to the old CMS demonstration in the early 2000s where the randomized control showed that the interventions were improving quality, but not reducing cost. And I think it's one of those shibboleths that exists within healthcare, at least in the United States, that improved quality will reduce cost. But I've searched through the literature, and I have to say, I have not come up with anything particularly compelling, and I think the CMS demonstration kind of confirmed that. So I threw this out earlier to the audience, so don't be shy. If you have an opinion about somewhere where value-based contracting is really demonstrating success, please speak up, because we're here to talk about value-based contracting, and it's been a great conference in terms of I've learned a lot from it, so that's good. But I remain interested in what can we do to change things so that we really do produce the kinds of results that the models are intended to produce. Anyone?
It doesn't really matter what program you implement. Healthcare trends have been between 5 and 8% for 30 years now, right? And it hasn't changed. Some years it might be a little bit higher, and we're at 7 or 8, maybe pushing 9. Other years maybe we can bend it a little bit, and we're at like 3, 4, 5%. But generally speaking, I think you're spot on. I mean, whatever programs we implement, it may have a good an impact on outcomes and clinical outcomes, and maybe an increase in life expectancy, and that's what's also helping to drive up costs, you know. But generally speaking, I mean, 30 years, and we've seen 5 to 8% trends year after year after year after year after year. I mean, I don't know. It's a great question.
And I think when you're on opposite sides of the table, everyone's suspicious, and everybody basically tries to poke holes, which is the right thing to do. But you're always on the edge of, is it really a real number? And we hear constantly from payers, I've been sold a bill of goods from people. I don't believe the 3-to-1 ROI. Doesn't matter what your methodology is. And so I think it's a matter of trust. I think that is, I know that's a very soft term, but I think it really is part of it because there's such differing angles that people are coming at this.
But the incentives that value-based contracting provides for the providers is a financial incentive. And I had a conversation yesterday with Jim. Maybe the providers aren't that interested. Maybe the amounts that they get aren't significant enough to change their behavior. Maybe they're more interested in trading income for leisure. Have we really taken that into account? Because the whole value-based contracting philosophy seems to be a financial one. So maybe we have to rethink how you get the providers involved in this. I don't know if the chief actuaries from Priority Health or Hopkins have opinions about these things, because you work in this day after day. But do the incentives really work with providers?
I've been doing this for 25 years, and trends continue to be the same, 5 to 8%. My opinion is it's not about giving more money to the providers, right? So I have seen value-based care work where you can generate a savings and give it back to the providers, but it's at what time can you reduce the cost to actually give it back to the member? And that's the challenge, that it's just left pocket, right pocket. So many discussions and so much of it is just taking profit from a payer to the provider side. And if you take it out of the payer side, you're never going to give it back to the member in lower premiums and lower cost shares. So until I start to see that occur, then no, we're not making a difference in value-based care until we give it back to where it belongs, which is the member.
Or the employer.
Yeah, I mean, I'll give 2 points. One is I'll speak to my experience at Mayo Clinic. And, when we looked at the primary care contracts, the problem is there isn't a standard framework for what value-based care should look like. I think that's the crux of the problem. So the primary care practice there was, and there, the incentive for, more leisure time and so forth is gone because the physicians are salaried. So, but they were accountable for 278 quality performance measures related to the dollars at risk across all the different contracts.
Good grief.
Right, so it becomes really hard to sort of manage what should that look like, and the most dollars that were at risk were 10% on one contract, but range from 2 to 10%. So you don't have large amount of dollars at risk, lots of different measures, so that you don't have a standard framework. And then in the commercial marketplace, I think the employers have not come together to sort of push that agenda forward like they could.
The thing that prompted the question that we explore in the book is when we did the doctoral research, we found physicians were motivated by 3 things and then a minor fourth: money, autonomy, and outcomes. Value-based care only touches money, but guess which one of those had the least impact on how a physician practiced care? Money. It was third and only slightly above affinity, which is a covariable to outcomes and autonomy. And so what prompted the question was, is value-based care as it's conceived by Medicare really working? And I think that the conclusion that we drew was that not until you solve that symmetry between the patient and the provider so that they're achieving autonomy or outcome of care. So I'm not claiming any answer. I think what was interesting, though, was the intersection of wearables and genomics, which are data inputs, empower the physicians to achieve those other two by doing less work that's higher quality.